Porokeratosis is a skin condition where the outer layer epidermis grows in a circular or oval patch. The patch looks a bit raised at the edge and may have a dry, scaly center. It is not contagious and can appear at any age, but it is uncommon. Example, think of a small, flat donut-shaped spot on the back of your hand that slowly gets a thin, rough border. The exact cause is not known, but several factors increase the risk. Genetics: some families have a history of porokeratosis, suggesting a hereditary component. Sun exposure: UV light can trigger or worsen the lesions. Weakened immune system: people taking drugs that suppress immunity, like after organ transplants, are more prone. Skin injuries: cuts or burns sometimes precede a lesion. For example, imagine a person who spends a lot of time gardening without sunscreen and later notices a ring-shaped rash on a sun-exposed arm. Typical signs include a raised ridge-like border that feels a bit hard, called cornate lamella, a central area that may be lighter, reddish, or scaly, itching, burning, or occasional pain. The lesion can be flat or slightly raised and may grow slowly over months. Example, picture a small circular bump on the foot that you can feel a firm line around its edge, while the middle feels smoother and sometimes itchy. Doctors diagnose porokeratosis by visual exam, looking at the shape and border of the patch; dermatoscopy, a handheld device that shows the characteristic ridge; skin biopsy, removing a tiny piece of the lesion for microscope analysis to confirm the cornate lamella. Treatment options depend on size and location. Topical medicines: 5-fluorouracil, 5-FU cream, or retinoids to slow cell growth. Procedures: cryotherapy, freezing, laser therapy, or surgical removal for stubborn spots. Monitoring: regular skin checks, because some lesions can turn into skin cancer. Example, if a patient has a few small lesions on the forearm, a doctor might start with a 5-FU cream and watch the patch shrink over weeks. Steps to help prevent new lesions or worsening existing ones. Sun protection: wear hats, long sleeves, and sunscreen, SPF 30+ whenever outdoors. Regular skin checks: look at your own skin monthly and see a dermatologist yearly. Avoid prolonged immunosuppression. If possible, discuss medication alternatives with your doctor. Treat early. Small lesions respond better to topical therapy, reducing the chance of complications. Example, a teenager who applies sunscreen each morning and checks his skin each month catches a tiny new ring-shaped spot early and gets it treated before it grows. Genetic research: mutations in the MVK, PMVK, and SLC17A9 genes have been linked to familial forms, opening the door for targeted therapies. New topical agents: terbinibulin 1% ointment, originally for actinic keratosis, showed promising clearance of small porokeratosis lesions in early trials. Laser improvements: ultra-short pulse lasers, for example picosecond lasers, can remove the ridge with minimal scarring. AI tools: smartphone-based apps using machine learning can flag suspicious lesions for doctor review, helping early detection. Example, a dermatologist uses a handheld AI scanner during a routine check. The app flags a faint lesion on the shin as possible porokeratosis.